Reliability of coronary angiography. When a doctor gets slightest doubt that the patient may be having some problem with his heart function, the patient is sent to a cardiologist. To investigate further, the cardiologist takes an electrocardiogram and in most cases direct the patient to cath lab where angiography is performed. Angiography is the entry point of a slippery chute that takes the patient to angioplasty or bypass surgery in about 60 to 90% of the cases depending upon the hospital and the cardiologist. One must bear in mind that the cardiologists and cardiac surgeons get huge incentive for taking the patient to these expensive and immensely profitable procedures. Many cardiologists state many tests to diagnose heart disease exist, but the one that is 100% accurate and determines further course of treatment is angiography. Before investigating further into this claim, we must first have rudimentary knowledge of the angiography procedure. In the year 1929, a German physician Frossmann inserted a urinary catheter in the vein in his arm and slowly pushed it to the heart chamber. To verify that it has reached heart chamber, he took X-ray images of his chest. By 1956, the technique became well developed. In the year 1960, a radio contrast dye was used to get clear images of the heart and to see whether the arteries are narrowed. With minor changes, this method is used currently. Brief description of angiography is as under. Patient is made to sleep on the bed of the machine. A local anesthetic is injected in the wrist or groin of the patient. A catheter 2 to 3 mm diameter is inserted in the artery of wrist or groin. A thin and flexible guide wire of length about 1 meter is inserted in the artery and is pushed to the heart chamber. A plastic tube that surrounds this guide wire is pushed to heart chamber and then the guide wire within it is gently removed. A radio contrast dye is injected through this tube up to the heart. With every beat, when the dye mixed with the blood circulates in the coronary arteries, X-ray imaging is carried out through many angles. The procedure of angiography is shown in figure on right. The images on the monitor of the fluoroscope are constantly watched on the monitor and are recorded in the computer. In these images, arteries appear as in the figure on right. After completion of angiography, the cardiologist guesses the place and size of block from the image. The report given by the cardiologist to the patient is a line drawing and looks like the one shown in figure on next slide. It indicates where, how much and how long are the blockages in arteries of the patient. If the angiogram shows only 1 or 2 blockages of magnitude more than 70%, the patient is advised to choose angioplasty. If there are more blockages in all the 3 coronary arteries, the patient is advised to choose bypass surgery. At first glance, the angiography appears to be foolproof and very reliable because it photographically shows whatever is observed in the coronary arteries vividly magnified on the screen of the imaging equipment. But when the whole procedure is systematically analyzed, the lacunas become apparent. Many of my patients have asked questions to me in this regard. My answers thereof are as under. Question 1. Is coronary angiography really 100% accurate? My answer. The primary objective behind angiography is to assess the condition of patient's heart disease, particularly whether the muscles of his heart are getting enough blood supply. There are many causes of the deficiency of blood supply to heart muscles as under. 1. Blockages formed by binding of oxidized LDL and calcium in between endothelium and intima media of the coronary arteries. 2. Intrusion of calcium in the walls of coronary arteries that causes arteries to stiffen. 3. The roughness developed on the inner wall of arteries by shells made by nanobacteria. 4. Heavy choking up of small coronary arteries caused by built-up of nanobacterial shells. 5. Backward leakage caused when the heart valves do not close properly. This in turn results from the deposition of calcium and other matter in the wall. 6. Reduction in ability of the heart muscle cells That in turn is due to intrusion of ions of metals such as lead, mercury, cadmium, etc. 7. Insult caused to heart muscle cells by free radicals generated in the faulty metabolic processes. 8. Stiffening of the heart muscles that results from intrusion of metallic ions into the muscle cells. This is called restrictive cardiomyopathy. 9. Dilation of the heart muscles caused by intrusion of ions of cobalt and cadmium as well as some bacteria in the heart muscles. This is called dilated cardiomyopathy. Besides the above 9 causes, severe anemia and methemoglobinemia also show symptoms similar to heart disease. They, however, are hematological disorders and not heart disease. In angiography, the severity and length of blockages are guessed, not measured. As elaborated later in this presentation, this guesswork is not reliable. However, for a moment, even if it is accepted that coronary angiography gives precise information about blocks in the coronary arteries, it assesses only the first of the 9 reasons given earlier. It does not evaluate any other reasons, hence angiography is inaccurate. Autopsies done on the bodies of hundreds of young soldiers in Vietnam War showed that many of the soldiers had severe blocks in their coronary arteries. However, they were found to be healthy enough to take part in the war. Similarly, autopsies of many patients who died of heart attack have shown that in majority of the cases, their arterial blockages were 50 to 60% and not 90 to 95%. Often patients have different kinds of heart disease, for example, heart wall disease or cardiomyopathy or hematological abnormalities like severe anemia or methemoglobinemia. In such patients, if bypass surgery is done on the basis of blockages in the coronary arteries, it is not correct. It must be emphasized that these surgical procedures are hazardous and dangerous. To sum up, angiography is insufficient and highly unreliable procedure. It not only fails in assessing heart disease but also the coronary artery disease. Question 2. Is angiography used in assessing the reversal of coronary artery disease by treatment through medicines? My answer. When a drug developed for reversal of coronary artery disease is tested, angiography is never used for the assessment, mostly because it is not considered appropriate. In such tests, patients who have been treated are followed up for a long time and the information of the adverse events experienced by the patient are recorded. Adverse event means death, heart attack, stroke, need to get hospitalized and need to turn to conventional surgical procedures like angioplasty or bypass surgery when the medicines are not proving satisfactory. Even though the technique of angiography was available from 1960, it was rarely used for the diagnosis of coronary artery disease prior to 1970, that is before the spread of bypass surgery. When bypass surgery proliferated, initially angiography was used for pinpointing the location of blockages so the new blood vessels can be joined to coronary arteries beyond the location of the blockages. Later, it was used as a tool to convince patients that they have blocks in their coronary arteries and bypass surgery is unavoidable. When angioplasty was developed in 1977 and was advertised very heavily, literally thousands of patients started turning to the new technique on account of its safety and need for less stay in hospital. Naturally, use of angiography became even more common as it is the first step in angioplasty. Question 3. What about the precision of angiographic technique? My answer. Initially, the cross-section of the coronary artery is circular. In such case, cross-sectional area of the flow path can be reliably calculated on the basis of measured diameter. Later, when the blockages develop in arteries, the flow path area becomes irregular. To calculate the area of such irregular shape, even to moderately reliable extent, at least two diameters are required to be measured simultaneously by two cameras focused on the same cross-section at the same time. In the commonly adopted angiography imaging, it is not done this way. Therefore, reliability of coronary angiography is low. In an article written by Brown and others and published in Circulation, the mouthpiece of American Heart Association, the information about such technique developed in the year 1976 was given. It involved photography of coronary artery by two cameras simultaneously and computer calculations of cross-sectional area of the lumen with such technique. However, computer calculations did not allow manipulations as it is done now. Needless to say that this technique, termed quantitative angiography, was discarded immediately. It appears that now even the manufacturer has stopped making such machines. Question 4. How reliably can a cardiologist guess the magnitude of arterial blockage? My answer. Even if it is accepted that the angiography shows the magnitude of blockages very accurately, there is no reliable method to interpret what is observed. It has been proven that as different cardiologists do guesswork in different ways, their assessment done without the knowledge of each other is highly erratic. In the year 1976, Gir got angiograms of many patients read by three very experienced angiographers. When the assessment done by them was analyzed, it was found that in as many as 61% cases, the assessment done by the three angiographers did not match with each other. In American Heart Association conference held in 1979, two researchers stated that they got same angiogram read by angiographer twice, but patients' names were changed. When their assessment was analyzed, they found that in as many as 32% cases, their assessment done in the first instance and second instance did not match with each other. This finding, being harmful to the spread of angiography and bypass surgery, was excluded from the proceedings of the conference. Besides this, Gridin in the year 1974 and Arnett in the year 1979 have published their research papers which conclude that angiography is unreliable. Question 5. What can be said of safety of angiography? My answer. Angiography is often considered to be safe by cardiology clients. Actually, it is dangerous to some extent. The reasons are: 1. In angiography, all the imaging of patient's body is done by means of X-ray. In this process, X-rays are thrown on the patient's body in quantity which is 20 times more than it is considered safe. This does not affect the patient immediately, but positively contributes to the process of body degeneration. 2. In angiography, death occurs when the guide wire penetrates in the artery, causing blood hemorrhage. According to research, mortality in angiography is about 0.16%. Thus, on this account, angiography can be considered as somewhat safe. 3. A special radiocontrast dye is used in angiography to clearly see the blockages in patients' coronary arteries. Later, when the dye flows to kidneys, in the filtration process, it is not easily excreted. This way, the patient's kidneys are affected and kidney disease starts. Research has shown that about 3% patients are affected by the dye in this manner. 4. When at the beginning of angiography, the guide wire is pushed to the heart, it goes on scratching the delicate endothelium. This long scratch is harmful to every patient. Particularly, it is harmful to diabetic patients because the wound does not heal rapidly and the clots formed at the scratch increase the probability of heart attack. On this count, angiography cannot be considered as safe procedure. 5. As stated earlier, when in beginning of angiography, the catheter is inserted in the artery at wrist or groin, a slight mistake can cause heavy bleeding. To remedy this situation, external blood supply has to be started immediately. In case of one of my friends, it became necessary to infuse 22 bottles of blood in his body. Fortunately, His blood group was common and getting the blood from the blood bank was rather easy. Thus, on this count, angiography can be considered very safe. 6. Today, the techniques of image interpretations are so well developed that it is possible to get images of angiography analyzed by computer as it is done in case of helium scan. Why are such techniques not implemented angiographically? The answer is simple. With such implementation, cardiologists will not be able to easily misguide people to surgical procedures. All the above elaborations indicate that angiography procedure is not as safe as it is made to appear by cardiology community.